Hello, everyone, and welcome to IVF Add-ons, Scientific, Ethical, Regulatory, and Legal Considerations. My name is Carmel Shachar, and I am the Executive Director of the Petrie Flom Center for Health Law Policy, Biotechnology, and Bioethics at Harvard Law School. We are delighted to welcome you to this panel today. Today, we will be talking about the challenges that in vitro fertilization, or IVF patients face as they decide whether to choose from a number of add-ons that are offered as supplements to the standard IVF paradigm. These procedures, of course, can add to the overall expense. Public and expert opinion is split on these costly procedures. It is controversial as to whether these IVF add-ons improve patients' chances of a successful pregnancy. Before we get started, a few logistical housekeeping things. There will be opportunities for you to ask questions. You might ask yourself, how do I ask questions? We welcome questions in one of two ways. You can use the Zoom Q&A button to submit questions, and our moderators and speakers will be looking at those questions. You can also join the conversation on Twitter using the hashtag IVF add-ons. Again, that's hashtag IVF add-ons. If you ask a question using that hashtag, center staff will be monitoring that and will pull that question into the Zoom Q&A. Ways that you cannot ask a question, please don't use the Zoom raise hand function. That little blue hand is really cute, but we will not be monitoring that, as well as we will not be monitoring the chat. Before I hand off this event to our presenters and panelists, I'd like to take a moment to introduce them and thank them. First, we have Eli Adashi, Professor of Medical Science and former Dean of Medicine and Biological Sciences at Brown University. Then giving us an overview will be Joyce Harper, Professor of Reproductive Science and Director of Education, Institute for Women's Health at University College London, Head Reproductive Science and Society Group, founder Global Women Connected and the Embryology in PGD Academy, as well as author of Your Fertile Years. In our PGTA add-on discussion, it will be chaired by Richard J. Paulson, Professor of Obstetrics and Gynecology, Aaliyah Tudor Chair in Reproductive Endocrinology, Division Chief, Reproductive Endocrinology and Infertility, and Director of the Fellowship Program at the Keck School of Medicine at USC, Kim Thornton, Reproductive Endocrinologist, Boston IVF, Assistant Professor of Obstetrics, Gynecology, and Reproductive Biology at Harvard Medical School, Nathan Treff, Co-founder, Chief Scientific Officer, and Clinical Laboratory Director, Genomic Prediction, and Norbert Gleischer, Medical Director and Chief Scientist, Center for Human Reproduction. Giving us concluding remarks will be Hugh Taylor, Anita O'Keefe Young, Professor of Obstetrics, Gynecology, and Reproductive Sciences, and Professor of Molecular, Cellular, and Developmental Biology, and Chair of Obstetrics, Gynecology, and Reproductive Sciences at Yale School of Medicine, as well as Chief of Obstetrics and Gynecology at Yale New Haven Hospital. To begin this event, I will now hand it over to our dear colleague, Professor Adashi, to give a few introductory remarks.
Well, thank you very much, Carmel, for not only this introduction, but all the hard work that preceded this affair. And welcome to one and all. Thank you for joining us to discuss a matter that is of import to all of us. And I could not be more pleased to see the individuals I see on my screen. It was December the 12th, 2019, so almost a year ago, when I met in Providence with Professor Catherine Rakowski, then president of the American Society of Reproductive Medicine, who could not be with us today. But the seeds of a meeting dedicated to IVF add-ons at the Petrie Flom Center were sown at that time. It just so happened that on that very day, the New York Times carried an op-ed titled "The Big IVF Add-on Racket." Not exactly the kind of headline one wishes for. The contributor of the op-ed, Ms. Pamela Mahoney Sigdinos, a patient advocate and an award-winning author, was a former IVF patient herself. Ms. Mahoney Sigdinos also authored the book titled "Silent Sorority: A Barren Woman Gets Busy, Angry, Lost, and Found." Later that very month, Ms. Mahoney Sigdinos co-authored a paper which saw press in Fertility and Sterility, titled "Do a la carte menus serve infertility patients? The Ethics and Regulation of In Vitro Fertility Add-ons." In the New York Times op-ed, Ms. Mahoney Sigdinos notes that careful examination reveals, and I quote, "a startling absence of robust research into the effectiveness and the safety of these add-ons. Despite this, their use is widespread and regulation of them is minimal," end quote. As Ms. Mahoney Sigdinos puts it, in quotes, "This is no way to treat patients at their most vulnerable," end quote. When it comes to IVF add-ons that are being offered absent the requisite scientific grounding, the United States is not alone. Some of the same is transpiring in the UK. Much of the same has also plagued Australia. Victoria may well be the only Australian state that requires that IVF clinics provide their patients with the evidence behind add-on treatments or the lack thereof. But back to our challenge at home. Thanks largely to advocacy efforts on the part of our predecessors, going back to the 80s, Congress, having been assured that self-regulation will do, refrained from legislating the nascent field of IVF. Indeed, the only major IVF-relevant statute ever enacted by Congress established the national CDC-based IVF registry, which gives rise to the annual fertility clinic success rates report. Absent FDA oversight, insistent on the safety and efficacy of potential IVF add-ons, it is really incumbent upon us, reproductive endocrinologists, embryologists, nurses, and all other IVF professionals, as well as upon our professional societies, to see to it that IVF add-ons lacking the requisite scientific grounding do not see the light of day. My hope is that today's discussions will not only shed light on the challenges represented by the IVF add-ons, but will also prompt action as appropriate. Thank you all yet again for your interest and for taking the time to join us today, your doubtlessly busy schedules notwithstanding. I'd like now to turn over the virtual floor to Joyce Harper, who is joining us from the UK. So from across the pond. Joyce, it's all yours.
Thank you very much. Can you see my slides now? Just double checking. Oh, I get brilliant. Thank you. It's a real pleasure to be part of this discussion. IVF add-ons. So I'll tell you how I feel about them. So just a disclosure, I think these things have already been mentioned, and I've worked with these various companies over the last few years. So let's talk about IVF add-ons. So yes, we've talked about the big IVF add-on racket. So I'm going to briefly describe what is an add-on, the need for evidence-based medicine, and I do a lot of work with the Human Fertilization and Embryology Authority in the UK. So I'm going to tell you about how we are regulating these add-ons in the UK. And as an introduction to the next part of this meeting, I'm going to give you a small example of my experience with PGTA. So what is an add-on? Well, my view is that it's any technique that is a variation or add-on from the routine IVF cycle, and that we could argue about that definition for the next hour, but let's leave it there, I think. But I also think we need to include any diagnostic technique that is of unproven benefit. So we've got things there like DNA sperm fragmentation testing, natural killer cell testing, etc. And I think this includes laboratory, clinical, and complementary treatments. And in my view, we need evidence to show that these technologies improve live birth rate. So I first wrote about add-ons almost 10 years ago, and this was stimulated from a visit to the ESHRE conference. The big ESHRE conference is normally about 10 to 12,000 people in our field. And this was the year that the time-lapse imaging was first presented at ESHRE. And I asked the people promoting this equipment, so have you got evidence to show that this is going to be of any use? But they were claiming it's going to improve live birth rate. And they hadn't done any work at all. They hadn't done even any basic studies. Fabulous piece of kit, absolutely, certainly for our IVF labs. But 10 years on, are we really claiming that using something like time-lapse is going to improve the patient's chance of live birth? So I'm part of the HFEA, what we call the SCAT committee, the Scientific and Clinical Advances Advisory Committee. I'm going to tell you a little bit more about that. And we have been working for quite a few years now on a website called Treatment Add-ons, and I'm going to go through some brief information about that. With this work with the HFEA, I've written a number of papers that have come out from this work about IVF add-ons, and I'll mention a little bit of this work. So let's talk about evidence-based medicine. Now, I think that we absolutely need to do solid research in these fields before we offer this treatment to patients and charge them money for these treatments. So this is our triangle of evidence-based medicine, and I think we need to be looking at the top part of this triangle, the randomized controlled trial and the systematic review. I think we need to look at other types of studies, but whether we accept them as part of evidence-based medicine, I don't think we should. We can certainly feed that information into our thoughts, but we need randomized trials and systematic reviews. And we need good quality studies. So I've shown here a paper Daniel Bryce and I wrote a few years ago about the Cochrane reviews on assisted reproductive technology papers. And in the Cochrane reviews, they always say whether they feel a study is of low quality or good quality. And unfortunately, a lot of studies are done and they're still of poor quality. And if we're looking at add-ons, in my view, the primary outcome needs to be live birth rate. And as I said, I do not think we should make patients pay. Unfortunately, there's been a number of good quality studies in this field, but we're just hiding behind our hands and we're ignoring the evidence. So this is the composition of the SCAT committee. Everything we do, the HFEA is fully transparent. The minutes and everything is all publicly available. And what the committee is looking at is advances in science and clinical practice, which are relevant to the authority's work. And the committee meets 3 times a year. And for the add-ons, it's been a huge part of work from the HFEA. And we have got Andy Vail as an external advisor. He's Professor of Clinical Biostatistics at Manchester University. And Andy does the systematic reviews of the data, and we do this regularly. He looks at the evidence, and then the committee will go through this as well. And we do look at RCTs and other studies. And then I chair the HFEA Horizon Scanning Committee. We meet once a year with experts around the world, and we feed information about potential new add-ons and new treatments into the SCAT committee. So this is how we have classified the add-ons. The HFEA have designed a traffic light system, and on the website it's very clear that we are just looking at the question, do these add-ons improve your chance of having a baby? I appreciate that there's issues around miscarriage, time to pregnancy, lots of other indicators that we look at, but we've tried to keep this as simple as we can. So a green traffic light, and yes, there are no green traffic lights at the moment, but a green traffic light would mean that there is compelling evidence to show that this technology should be used. Amber means there is conflicting evidence. Some studies showing there is, and some studies showing there may be not evidence. And the red means that either the studies haven't been done, or the studies are showing that there is no improvement in using this technology for IVF patients. So I wanted to just give a bit of information about pre-implantation genetic testing. This was developed for couples carrying inherited disease, and there's what we do is we take some cells from the embryo. We either do it here at the very early embryo, just take some cells here which are representative of the maternal DNA. We can take a cell here at the cleavage stage, or what's more commonly done now is take some of these trivectoderm cells at the blastocyst stage. And then we take these and use these for our genetic testing. And this procedure was first done in 1989 at Hammersmith Hospital, and I joined that team in 1992. And it was purely developed at the beginning for inherited disease, such as cystic fibrosis and beta thalassemia, etc. So when I joined the team in 1994, we wrote a paper on the current status of pre-implantation diagnosis, as it was called then. And we looked at all the centers, we got their information about how many cycles, etc. they'd done. And then people found this really interesting and asked me to redo this. And I redid this in 1996. And this founded the birth of the ESHRA PGT Consortium. This is us here in 1997. And the consortium has been collecting world data for over 20 years. So out of PGT for inherited disorders came PGT for aneuploidy, or PGT-A, and this has been highly controversial. So this procedure is the classic add-on. People claim that this technology, many other things as well, but primarily will increase the chance of a woman having a child. So the first version of this was called PGT version 1, and it was mainly the cleavage biopsy and a technique called fluorescent in situ hybridization, which looked at a handful of chromosomes. So this first started in the US in 1995, and in 2010, the ESHRA Consortium wrote a position statement saying that over those 15 years, there'd been 11 randomized controlled trials. Not one of them had shown an improvement of using this technology on live birth rate, and some of them had actually shown a significant reduction in live birth rate. So we said we need to use the new technology that was just coming out there, which was called arrays, that could look at all of the chromosomes, and we needed to demonstrate that this was going to help. And this technology used to be called PGS, just to confuse things even more, but PGS is PGT-A, they're the same thing. So PGT-A version 2 looked at these methods that could look at all of the chromosomes rather than just a handful. And over the last 10 years, there's been in my opinion, three large RCTs that are worth discussing. Carmen Rubio's group did cleavage stage biopsy, and they were the only one of these three studies that found an improvement in live birth rate. The middle paper is from ESHRA on polar bodies. No difference in live birth rate. And here is the STAR trial on blastocysts. Again, no difference in live birth rate. The first two studies did show an effect on miscarriages, lower miscarriages in the PGT-A group, but the STAR trial, which is mainly how people are doing PGT-A now, which is blastocyst biopsy, did not show any effect on miscarriage, but this is often quoted. And we have to consider the live birth rate, the cumulative live birth rate. So the subsequent birth rate from embryos that were frozen in the original cycle. And all of these studies had less embryos frozen in the PGT-A group. More embryos were discarded. And Carmen Rubio's follow-up of her cumulative live birth rate showed that the difference she found in her original study was eliminated when you added on the cumulative live birth rate. So I wonder with these two, Escher and Starr trial, that showed no difference, when we add on the cumulative live birth rate, we might even see a reduced live birth rate in the PGT-A group. So I always ask the two questions. What are you telling your patients that this technology is going to do? And are you charging them? These are two recent studies that we've done. The first, we compared the UK and USA data. In the UK, PGT is currently only 1% of ART cycles. I do think that's gone up in the last couple of years. And in the US, we looked at 4 years and we saw now almost a third in the last data we looked at. And on the graphs on the right, we can see the percent of PGT compared to the routine IVF that's done in clinics. And we can see that this has gone up over the recent years. And there's now 3 clinics in 2017 that did PGT in every single cycle in that clinic. And this is our latest paper. We looked at how UK clinics are advertising add-ons. We looked at assisted hatching, which is given a red rating from the HFEA, PGT-A, which is, there's 2 here because one's cleavage biopsy and one's blastocyst biopsy. And time-lapse imaging is given an amber signal. And the graph at the bottom shows that up to 40% of clinics are advertising PGT-A and almost 60% are advertising time-lapse. In the paper, we go in more details about the clinic claims. I won't go through them now, but most are saying they're going to improve live birth rate. And this is the cost that we're adding on, around about £3,000 for PGT-A. And our most recent data just submitted, we looked at complementary therapies. Acupuncture's done quite a lot in the UK. And again, a number of claims of the treatment, but definitely claims that it's going to improve IVF outcome. So a few of us got together a few years ago, instigated by the HFEA, and we wrote this consultation document. And we said patients deserve consistent evidence-based treatment. There should be evidence for their patient's demographic and not extended from one group to another. And doctors should declare financial interest. And we said we had to be careful about clinics reporting their own data. This is very common in the UK. Or in our clinic, we find X, Y, and Z. And I always say if it's good data, then it should be published. So in conclusion, our solution in the UK is that the HFEA have got together with the Competitions and Markets Authority, the CMA, and they've just last week produced this draft guidance for fertility clinics on consumer law. And they've looked into what clinics are claiming different add-ons do. And this goes wider than just add-ons. Lots of information here. This is in the public domain, and also the second document is some qualitative research that they've done. So they're waiting for about just over a couple of months for people to give some consultation on their document. So I think in IVF, we need to think, are we making families or are we making money? And in the CMA report, they've said that the UK fertility market is now worth 320 million annually. And there are lots, many IVF and PGT millionaires out there. So just like to thank my team, and then this is my social media. Thank you very much. So I think that will segue us nicely now into our roundtable discussion.
Volume.
You're muted, Rick.
Yeah. Just as I had started screening, I was so focused on sharing my screen. How about now? We seem to be doing all right. All right, well, very good. So we're now going to segue to the group discussion. And Joyce did a great job of teeing up the topic. I had anticipated doing that as well, so I'll gloss over some of these slides. I presume everyone in the audience understands the concept of in vitro fertilization, which is on the right side of this slide, mimicking as it does what happens in vivo on the left side with natural ovulation. fertilization, and then transport to the uterus. All of it on the right side of the screen takes place in the laboratory. And I wanted to show you sort of the stages of embryonic development, just so that we would sort of keep in mind what happens if there is a mistake that is made, for example, in the first division. Actually, when the polar body is put out, that is where most meiotic errors happen, and that there can be errors in cell division in the DNA being split later on in embryonic division, and that leads to mitotic error. So remember, there's all kinds of errors that can take place, and all of these influence the potential for what happens with PGTA, pre-implantation genetic testing. Joyce talked about PGTA 1.0, cleavage stage biopsy, which was analyzed by fluorescent in situ hybridization, was widely utilized. We saw it here in California. I assure you that all of the Beverly Hills clinics were advertising this as the be-all and end-all. And as Joyce said, it was found not only not to improve outcomes, it actually hindered outcomes in some cases, which gives you pause. Why is that? How is it possible that even if the information were to be imperfect, you would expect that there would be some improvement? So there had to be not only lack of good data, the information was imperfect, but there had to be some harm that was coming to the embryos as a result of the PGTA. And I want you to keep that in mind, because I think that is still going on. The two components of pre-implantation genetic testing is that it's imperfect and that there is trauma to the embryo that happens. So we're all utilizing now PGTA 2.0, or those places that are doing it, which means it's a blastocyst stage biopsy where you take a sample of what's called the trophectoderm, and I'll replace the picture of the blastocyst here with a cartoon just to remind us that the cells that are being biopsied are those from the outer layer of the blastocyst. These are destined to become the placenta, whereas the inner cell mass here is what will become the fetus. And so really this is very analogous to chorionic villus sampling that patients do at 10 or 11 weeks of gestational age, where some of the cells are taken from the placenta. And it's very logical to accept, or to expect rather, that the sampling of the trophectoderm would be no more inaccurate and no more harmful than what would happen during chorionic villus sampling. So I want to frame the discussion by pointing out that there are some very specific goals of PGTA, which is to ascertain the chromosomal content of the embryo. And to the patients that are requesting this, and I assure you that patients come in every day requesting this, they want to avoid abnormal conceptions and births, because they don't realize that this is a relatively uncommon and rare event. They also have heard that it avoids miscarriages. They're not really thinking about increasing pregnancy rates, but that is the bottom line for us. That is what is being marketed to IVF practitioners. And the problems are twofold. One, how accurate is that information about the embryo? And two, what about the trauma from the biopsy? So the inaccurate information comes from several different sources, and I know that Norbert is going to address this in his talk. So first of all, there's an inherent biology of the pre-implantation embryo that we do not understand. The trophectoderm may not reflect the inner cell mass the way that the placenta does, and there can be a major sampling error. In the sampling of the trophectoderm, of the outer layer of the embryo, we're only taking a few cells. So that may be a sampling error. Those may not be reflective. And in addition to that, as you pull off those cells, those are not removed surgically with surgical steel. They are removed with a laser. That laser vaporizes a part of the cell, can easily cause heat damage to the DNA that is coming out, and therefore contaminate the results, and therefore lead to inaccurate conclusions. And there's the very real concern about the trauma to the embryo from the biopsy, therefore leading to decreased implantation potential of the biopsied embryo. It's being advertised like you wouldn't believe. Look at that. It says PGTA increases the chance of pregnancy, helps you have a healthy baby. That is what's being advertised to the public. These are the numbers out of one of the brochures that I was able to get. And you can see, if you just look at one group, let's say under 35, that the control group is at 50%, and they claim they go up to 65% after that. The problem, of course, is they're tossing away half of the embryo. So even sort of a cursory mathematical understanding says if your control group has a 50% implantation rate and then you're discarding 50% of the embryos in the study group as a result of aneuploidy, you would expect that all of the remaining embryos would implant at a 100% rate and not 65%. This is the STAR trial that Joyce alluded to. There was no increase, in fact, in implantation rates in the group under age 35. How is that possible? It is not possible unless, of course, there must be damage to the embryo from the biopsy. And she already alluded to the fact that there was no decrease in miscarriage rates, and that is, of course, true. So the conclusions that I want to sort of lead with, and that I'd like for you to keep in the back of your mind, is that PGTA is logical and appealing. And I assure you it is requested by patients. If somebody told me that this is what it does and that nobody told me about the losses, I would request it as well. I think it is currently overused. It's being marketed with very preliminary data. It is certainly not cost effective in achieving pregnancy at this point in time, and it is very inefficient. This is the additional subliminal argument for why PGTA is being used. Additional egg retrievals are needed for the patients. This is a very real financial add-on for the clinic that uses PGTA. Nevertheless, I believe that the subject is imperfect but improving, and I do think it's going to be an integral part of the fertility treatment of the future once we solve it, because the concept of testing the chromosomal content of the embryo is that logical and that appealing to patients. So I will stop here. We have three panelists with us. I'd like to start with Norbert Gleischer, who has been also focused on this topic for quite some time. So Norbert, take it away.
Thank you very much, Richard. I hope I can get my slides going. Yeah. Okay. Can you see my slides?
Not yet.
Good.
Okay. How about
Now?
now?
Yes.
Okay. All right. So first of all, a big thank you to the Petrie Flom Center for giving me again the opportunity to participate in one of your events. And I'm delighted actually to have chosen to concentrate on an issue since both of the preceding speakers have so well laid out what the issues are that we are facing today with PGTA after so many years of use. There's one thing neither one of them, however, mentioned, and I think it is important to note. And that is that until 2010, IVF all over the world, including the US and Europe, steadily increased its pregnancy rates and live birth rates. Around 2010, it started flattening. And since 2010, there has all over the world, almost without exception, been a dramatic decline in live birth rates in IVF. Now, association is not causation, but you may have heard from Joyce that this whole concept of add-ons really started becoming popular around 2010. So unless this is an incredible coincidence that is happening all over the world, we have to believe that there's a connection between that sudden appearance of all of those add-ons and actually declining pregnancy rates. And since I'm known as having opposed PGTA use, or PGS as it was called earlier, for a very long time, I asked myself ahead of this presentation, what is the ultimate point that I can bring across in 5 minutes in order to support my negative position about PGTA? And so before I give you that, here's my usual conflict statement. And you can see that on a general level, I have a number of conflicts. None relates to PGTA, But maybe the most important point is not listed on my conflict statement because it is actually the opposite of in conflict. Our center strongly recommends against use of PGTA and has done so forever, which in basic terms means that we have foregone about at least 20 to 25% of cycle revenue with every IVF cycle that we do, because at least in the US, by now, there's a very significant portion of IVF centers that practically do PGTA in every cycle. So there are many good reasons why PGTA should not be used, in my opinion, but I think that none is more convincing than the evidence presented by healthy birth from transfer of so-called chromosomal abnormal embryos that are destined for disposal. Well, in other words, the alternative option is 0 in terms of pregnancy rate, in terms of even trying to get pregnant. And therefore, what I'm going to present to you as what I think probably is the strongest argument against using PGTA is our center's experience with patients who had IVF at IVF centers, both in the US and in Europe, went often through more than one IVF cycle without having a single euploid embryo, and now we're stuck with a whole bunch of chromosomally abnormal embryos that their own IVF centers refuse to transfer. And so between 2017 and 2020, until about 6 months ago when we analyzed these data, 50 couples shipped those embryos to our center. We got 249 abnormal embryos that were in this way refused transfer. And by the time we analyzed the data I will be showing you, 40 of these patients had 112 embryos transferred. Now, as may be known to many of you, we serve the oldest patient population of any IVF center in the US. And you can see this reflected even here. So what I'm going to show you as outcomes of these data is not even the average IVF population. It's an above age, older IVF population with a mean age of 42, median age of 42 years. So here's what happened. In those transfers, we achieved 15 clinical pregnancies, meaning pregnancies that were seen on ultrasound. This is a 37.5% clinical pregnancy rate in 41-year-old women. I would say this is at least a normal pregnancy rate. It may indeed be an unusually good pregnancy rate. Now, our live birth rate was only 15%. Even that is a good rate considering what the alternative was, but I will show you in a second that the real rate is actually closer to 20%. Again, by all means, a normal rate expected in 41-year-old women. The loss included 7 first trimester losses for a 17.5% loss rate. Now, I want to remind you that the average miscarriage rate in spontaneously conceived pregnancies over all ages is 15%. So 17.5% is not bad. The reason why our loss rate was bigger was that 3 second trimester losses happened within 1 week after amniocentesis. And these patients underwent amniocentesis because our informed consent at that point required early prenatal genetic testing if they wanted us to do the transfer. Based on these results, we have since changed that. We still recommend early pregnancy diagnosis, but we no longer mandated it in the consent. So these should have been pregnancies that should have been delivered, and that would have taken our live birth rate closer to 20%. But maybe the most important point in the story is that in order to achieve all of this, we haven't even used yet half of the embryos of these patients. In other words, they have the same pregnancy chances that I have just shown you still sitting in our freezers or in our tanks. So think about this. Think about how many so-called chromosomal abnormal embryos are out there in the US, in Europe, all over the world. Hundreds of thousands. Think how many pregnancies and live birth are sitting in those freezers with the patients even not knowing that they have these chances. It is really mind-blowing, and what is even more mind-blowing, as Joyce and Richard made the point, that all of this is happening without anybody doing anything about it. So let me summarize. I think what I've shown you is, first of all, that transferring so-called chromosomal abnormal embryos appears not only established, but necessary. I think it is inexcusable not to transfer those already existing embryos. And secondly, of course, the value of PGT-A as a diagnostic test appears further diminished by those data. Thank you very much.
Thank you, Norbert. If we can get you to stop sharing, then I'll have Nathan bring up his. So as I mentioned in my introduction, there are two problems. One of them is inaccuracy, and the other one is trauma from the biopsy. And Norbert's data obviously points towards the lack of accuracy. And we'll let Nathan take it away.
Yeah, thanks. It's amazing how long it takes to present anecdotal evidence. And actually, to evaluate evidence, you have to read past the abstract. So this is actually, it's kind of a stacked deck against PGT. And so I'll do my best in 5 minutes. It's kind of like trying to fact check Donald Trump 4 years of statements in 5 minutes. Conflict of interest, I think mine is obvious, and others like to avoid the fact that they do have considerable conflict of interest when opposing PGT. They make more money by having failed transfers. And it's a lot like a situation where a car salesman sells cars that half the time they know the brakes don't work, but because they can't do the test, they're going to say it doesn't work, because individuals would go to another salesman where they can do the test, and they would lose money as a result of that. So there's a significant amount of money made by opposing PGT. As we know, PGT is pretty common in the US, 40% in 2018. And I want to reiterate the importance of testing for aneuploidy. It's the most common genetic abnormality in human embryos. It's the most common genetic cause of infertility and the most common cause of miscarriage. I think if you actually imagine having a patient go through a miscarriage and come back and ask what happened, and you tell them, well, there's actually a test for that, they might be upset. It's something to consider, that aneuploidy is a significant risk factor for infertility. A lot of opponents of PGT argue against the ability for PGT to work because mosaicism is so common, and it actually is not. It's really a situation that I believe was made up by industry to suggest that they have the best test available. But in fact, the frequency in ART or spontaneous pregnancies is equivalent and relatively low. And it suggests that IVF ART is not a risk factor for mosaicism. If you look at well-done studies where the embryos have actually been retested, the prevalence of mosaicism is relatively low. And a lot of people reference a video actually by Dr. Paulson on this topic. And it's not to criticize that video in any way, but actually to criticize the HFEA directly for a complete lack of competence when evaluating data. I once heard a representative suggest that PGTA RCTs are flawed, but Dr. Paulson's video is great and I use it to counsel patients. So imagine not using actual peer-reviewed evidence and instead using a YouTube video. Another member of the HFEA, which is on the panel today, Joyce, was asked once if there was good data to show it worked, would you change your mind? And her answer was no. So this is the situation we're in, and when someone is unwilling to be open to innovation and new data, it's really an uphill battle. There's really no reason to argue with people that have that position. So as I said, mosaicism is relatively infrequent, and unfortunately, some labs do actually report a high rate of mosaicism, and that's essentially due to the fact that the methodologies used inflate the prevalence of mosaicism. That's led to a lot of problems in the clinic and for patients. It turns out, though, that these methodologies are meaningless in terms of whether or not they can predict outcomes. For example, this study transferred 1,000 so-called mosaic embryos, which led to 200 pregnancies, 0 of which confirmed the original prediction. So 0 true positives. If we look at other data, for example, here, when comparing euploid to so-called mosaic embryos, the live birth rates were not different. Another study demonstrated this as well. So essentially these predictions with intermediate copy numbers trying to predict mosaicism are in fact meaningless. Most people would, well, a lot of people would argue that there must be self-correction. These embryos self-correct these abnormalities that are real. And one outcome from that is uniparental disomy, which is exceedingly rare. And so one idea to our field or to move forward with what we're doing with PGT is to actually just stop calling embryos mosaic to begin with. And it's one point that Dr. Paulson and I have agreed on. If anyone's interested in the full editorial, you can find it here in Fertility and Sterility Reports. So how can we implement PGTA effectively? One way is to actually avoid and not predict embryos as mosaic. So when you do in fact designate an embryo as mosaic, or excuse me, euploid or aneuploid, the predictive value is high. And my colleagues like to ignore this data. There was 100% predictive value when the embryo was designated as aneuploid for a failure. So 0% sustained implantation, and products of conception, 100% confirmation rate, which is much different from confirmation of mosaicism, where it was 0%. And Dr. Gleicher also confuses the difference between uniform and mosaic aneuploidy. In his own data presented at ASRM, we can actually look at outcomes from embryos that were designated as uniform aneuploid. And what you see is 0% sustained implantation, 5 miscarriages, unnecessary miscarriages, and when evaluated, 100% confirmation rate. This was not IRB approved, it's not registered publicly, and I think that is potentially an issue that hopefully will be addressed later in the session today. The safety was brought up earlier, and there was a large study showing that there's no difference in sustained implantation as a result of embryo biopsy. IRB approved study published in FNS. My colleagues also like to ignore the fact that there is an intention to treat randomized clinical trial showing a significant improvement in delivery rates with the incorporation of PGTA. This was in a relatively young group where mosaicism was not predicted in the embryos. We also have seen a lot about the STAR trial, and I think one consideration is not necessarily just the damage done, but when using a test that includes mosaicism, you have a higher false positive rate, which impacts population under 35 more because the prevalence of aneuploidy is already lower to begin with. And this is the type of information that we should try to be looking at. How can we better apply this methodology? One way is to not report mosaicism, but from this data, you can say that in patients under 35, they probably shouldn't send their biopsies to a lab that reports mosaicism. It does show evidence for working in over 35. And one statement from the HFEA actually, again, gets it wrong. They suggest it works for patients under the age of 37. This is the largest randomized trial performed to date. It's not a small study, and it shows benefit in over 35. So to conclude, I think there is no other IVF add-on with more rigorous evidence of clinical utility. There are limitations we can talk about. It doesn't work for everyone. It doesn't work for young people sending biopsies to labs that report mosaicism, for example. And that's why I think it is important to acknowledge this when reviewing the literature and actually read past the abstract. Finally, I'll conclude with this comment that I think it's unethical to fail to inform patients, be incapable of providing or prevent access to PGTA. I actually think that patients should have to sign a consent when transferring untested embryos because of the known risks of doing so. Thank you.
That was great. Well, now you have seen the ends of the bell-shaped curve in terms of opinion. And indeed, Nathan and I hope you all read our opinion on why mosaicism should just be, so we should stop calling things. Anyway, Kim, take it away and take us on to the ethical considerations of trying to transfer embryos when we have an imperfect test and an imperfect situation. How on earth do we make a perfect ethical decision in that setting?
Great. Well, listen, thank you again for the Petrie Flom Center for the invitation. I was going to address mosaicism, at least initially, just because there are many centers that, in conjunction with their IVF and PGTA, do report mosaicism, which, as you have heard, is the presence of more than one chromosomally distinct cell line in a single sample from a single individual. And this is just a slide that depicts, in theory, the way that embryos can be mosaic. You can have an embryo that's total mosaic, where both the trophectoderm cells and the inner cell mass have these two cell lines. Excuse me. You can have an embryo where the inner cell mass only is mosaic, an embryo where the trophectoderm is only mosaic, and then a situation where the inner cell mass is completely normal and the trophectoderm is completely aneuploid, or vice versa. With embryos that are diagnosed as mosaic, because they can either be fully euploid, fully aneuploid once they implant, it's inherent upon us to make sure that we're appropriately counseling embryos. And certainly, if counseling patients, if you transfer an embryo, certainly mosaic embryos that are transferred can either not implant, they can implant and then ultimately result in miscarriage, or result in a live birth, either with a normal or an abnormal phenotype. Some of the data with regards to embryos that have been transferred, that have gone on to become pregnant, when patients have had CVS, they have demonstrated either confined placental mosaicism, and that's where mosaicism is strictly in the placenta, and that happens in most instances, about 87% of the time. That being said, the obstetric outcome in these patients indicates a higher incidence of pregnancy loss, some growth restriction in terms of fetal growth, and other obstetric complications. And this is thought to be related to where the mosaicism is located within the cytotrophoblast. There can also be true fetal mosaicism, and in that case, it happens in about 13% of the cases, and generally involves chromosomes 21, 18, or some of the sex chromosomes. And then the concept of uniparental disomy suggests that there is a post-zygotic rescue event, where you either take a trisomy and that embryo is rescued, and you end up with a disomic embryo with both chromosomes resulting from the same parent. In those instances, you may have imprinting disorders, which again cause problems in the resulting offspring. Certainly, prior to doing any sort of pre-implantation genetic testing, patients should sign informed consent or have informed consent so that the frequency of mosaicism in the particular testing lab that the cells are being sent to is discussed, the challenges in interpreting the results with regards to mosaicism, the fact that there's limited data with regards to outcome, and for those embryos that you do transfer, there is the potential for anomalies, growth restriction, or adverse perinatal outcomes. Additionally, clinics differ with regards to whether or not they report mosaicism or not. So patients need to be aware of whether the clinic that they're working with identifies mosaic embryos. And then finally, always discuss the option not to test embryos with pre-implantation genetic testing. Certainly, if embryos that are mosaic are going to be transferred, there are stratification paradigms that have been developed. These have either been developed so that embryos are transferred based on the percentage of mosaicism or not. And this is typically in those clinics that don't even report mosaicism. And they just establish a cutoff above which embryos are considered either abnormal, and if the mosaicism is less than a certain percentage, generally 20 to 30%, they're considered normal. But some instances you can identify embryos based on the specific chromosome involved in the mosaicism and make a determination as to which embryos should be transferred. Whether embryos are monosomic or trisomic may influence, and then whether there is a full or partial chromosome affected may influence whether that embryo gets transferred. So what principles should be considered in terms of making a decision to transfer abnormal embryos? Certainly, from the standpoint of patients, we have to consider the principle of both reproductive liberty and patient autonomy. The principle of reproductive liberty states that all individuals have the right to reproduce, whether they are infertile or not, and that right should be private and should be respected. And then certainly the patient should have the right to make decisions about their health care. That being said, if you are a physician involved with patients who are making a decision, for instance, to transfer an embryo that's abnormal, there is physician autonomy that comes into play, in that the physician can decide whether or not they want to enter into this relationship. They don't really need to subjugate their own values if they're not comfortable proceeding with transfer. We have always operated under the paradigm of reproductive non-maleficence, which is that we would do no harm, and certainly transferring embryos that are abnormal may be considered as such. So for many individuals, the idea that you would transfer an abnormal embryo is paramount to doing harm, and that would be contrary to what we would normally do. A counterpart to that is procreative beneficence, and that posits that physicians and parents really have the moral duty to select any embryo to transfer so that the child that results would be expected to have their best life. And if we were going to do that, then that would argue that you wouldn't transfer an abnormal embryo or an embryo that has the potential to be abnormal if there were other embryos available. And then finally, we have an obligation to the offspring to make sure that, we are doing the best for them, because they're not actually able to speak for themselves preconceptually. And then there's always the concern regarding legal and professional liability. Certainly physicians can have parents waive their rights. However, you can't waive the rights of children who have yet to be born. And so those are all considerations that need to be considered before you embark upon the path of transferring embryos that are abnormal. So I'll stop there and then we can discuss further. Thank you.
All right, well, thanks very much, Kim, and I'd like to thank our panel. I'd hope that we'd have some time for conversation, but obviously we all are very passionate about our points of view, and we have run out of time, so I will hand it over to Hugh. Before I go, there was a question in the Q&A about how I can possibly think that PGTA will become a standard part of IVF, and that is because I see the data on both sides, because I've seen the data from Nathan's group that shows 0 sustained implantations after transfer of aneuploid embryos. And I've seen the data that shows 0 harm to the blastocyst. Those are very carefully selected embryos, very carefully selected situations. If we can figure that out for all the other embryos, I think we're going to get there. And that is why, shockingly, I agree with everyone on the panel. That is how to stay in the middle. All right, Hugh Taylor, president of ASRM, will take us home.
Well, thank you. And because we're already over time, I'll keep my comments brief. This has been a wonderful, spirited debate, and I thank all the panelists for their frank discussion of the data. It really brought all the issues home. This is a controversial topic. It's a biologically complex problem. It's one where the success rates are now under active debate, as you've seen. And it's expensive and not covered by insurance, or patients are paying out of pocket, which really introduces a new complexity. So the implications of this are profound. But our debate here is really nothing new in medicine. Typically, in the history of medicine, things are discovered anecdotally. Small case series follow. And when do you introduce that to the public? When do you introduce that into the practice of medicine? Not always do we wait for prospective randomized trials, large randomized clinical trials. We have some here in PGT, certainly do have some that we can depend on, but even randomized clinical trials have bias, are not always 100% definitive. There are many bias, including selection bias. Did you really study the right group, or is there a particular subgroup that is more reflective of where the test is really beneficial? And all these things have to be taken into account. In general, we tend to oversimplify new technologies and the capability of technology, and all technologies have inherent error limitations. And we also routinely oversimplify how we think about biology and the clinical problem. I mean, who would have predicted that mosaicism is such a debatable topic as it is now, and that we'd be in the midst of this? So all of these things make this much more nuanced. The other thing I think we need to know is that PGT is just one example of a large number of add-ons that are available through IVF. We heard about it a little bit from Dr. Harper and some of the different techniques that are available. There are dozens of them. Almost everyone having an IVF cycle uses at least one of these add-ons, if not multiple. Many others. I mean, my research is in the field of endometrial receptivity, and I think the endometrial biopsy or endometrial scratch was something, there were several case series and reports of real benefit. But when a large randomized clinical trial was published last year in the New England Journal of Medicine that included over 1,300 patients, there was no benefit. So I think we really need to keep in mind that these things need to be tested, and we need to bring them forward. There are a whole lot of others, other endometrial receptivity tests that are, again, not well defined, not well studied in randomized clinical trials: microbiome, embryo glue, immune therapy, mitochondrial testing. We've heard about time-lapse assessment of embryos, assisted hatching. These are all types of things that have been studied and not all have proven benefit, and we have to really think about the bigger principles. When is something ready for clinical application in the general population? It's not confined to just PGT. We want to make sure we bring things forward that are ready for clinical application, but we should never stifle innovation and creativity. It's this entrepreneurship that has allowed us to develop all these new techniques that have really helped a lot of people. IVF itself was born from this type of individual creativity and innovation. So was ICSI, a technique that was originally an add-on, but has clearly cured many forms of male infertility. We can debate whether it's overused or used appropriately now, but clearly innovation is essential to moving the field forward. I think what's important is that we don't stifle innovation, that we inform patients the best we can of the state of the knowledge, that we have the transparent discussion with our patients that has to include cost as well, and that it really is a shared decision-making process. We go back to the fundamentals of how to relate to our patients. Do we create something like the Human Fertilization Embryo Authority that we heard about today in the UK, in the United States? Perhaps. We already have organizations like ASRM through its practice committee that reviews the literature and makes recommendations. So there are other ways in place to discuss this data in the United States now. But PGT is just one example of IVF add-ons, and they will increase. As we have more technology available, you can be sure that this will only accelerate, and it's important we think about and answer these questions now. Even in the field of genetics, we're on the verge of an explosion in our ability to do genetic testing. Are we on the verge of testing embryos with whole exome sequencing or whole genome sequencing? That technology has gotten cheaper than ever, more accurate than ever, and we can get by with fewer cells, smaller amount of starting material. We can target every gene, and we can find more disease-causing genes and potentially eliminate those. But what else will we start to select for? What else can we select for? What should we be selecting for? Gene editing is on the horizon. As you all know, the Nobel Prize was given this year for the CRISPR-Cas9 technology that lets us edit out abnormal genes. Should we be doing that, and what should we be editing, and what are the ethical implications of that? And perhaps even in the future, although this is still in the realm of science fiction, but we have already gotten to the point where we can make gametes from stem cells. Can we someday make embryos from stem cells? Will we be in a world someday where we may have hundreds, if not thousands of embryos that we can test with extensive genetic testing? What should we be testing for? What should we think of as ethical, and what can we practically predict? That world where we might be testing to find that perfect embryo frightens me. There are a lot of ethical concerns that come into play there. But we're now entering a point in history where we'll not just ask whether a test we perform can practically be done and whether a test we perform improves pregnancy rates. We'll be asking what tests should be done. And I think that's a very profound question going forward. So I want to end, we're already over time. I want to end by thanking all the panelists for this vigorous debate. It's important we get to answer this question and many more. This is becoming a very exciting and troubling area in human biology and in human history, really. It's how technology will impact the future of the human race, and we need to think about and answer these questions. So thank you.